Yeah, I find that super helpful on the YouTube channel.
Okay, good. So let me go back. Okay, so on this page, just make sure you know all the digestive organs on the accessory digestive organs and the actual digestive organs. Okay, here we have ingestion of food, and we have two forms of breakdown. We have chemical breakdown and mechanical breakdown. Okay, chemical breakdown are things like your digestive enzymes, and that starts in the mouth, and it continues through the various parts of the alimentary canal, which is your tubes that are inside of you, part of your gut. Okay, then we have mechanical breakdown, which is like your teeth. Okay, the stomach itself actually does its form of mechanical breakdown. Okay, so those two things are important, right? So once you ingest something, actually introducing food into the mouth, then you have to chemically and mechanically break down the food. Okay, so here's um, a side note, a clinical side note here. So going back to what we talked about with um, helping people turn over a new leaf with their diet and lifestyle, one of the starting points is assessing what people eat, the actual quality of food, and how people eat. Okay, so what people eat and how people eat. So some people, just as their own technique, like inhale their food. They bypass the mouth, meaning the mouth is uh, the beginning part of chemical and mechanical breakdown of food. And they don't take advantage of that. They take a bite and basically swallow the food. Like they don't really chew their food completely. So that's how they eat. Another thing to assess is how they eat is, do you eat stressed? Do you eat on the go? Do you eat while watching TV? Are you eating in your car? Or whatever, like just how are you eating? The body does not do very well when you're eating in a hurry, when you're eating under stress. Okay, so that's another technique to get into. Um, so the mouth breaks down food by chewing, the stomach breaks down food by churning. Okay, and after you churn food in the stomach, that turns it into chyme. Okay, now I like my blender analogy. If you take food, put it in a blender, and turn on the blender, it liquefies the food. That's kind of it's kind of like what your stomach does. Okay, it's a very, very good analogy. You introduce food, eventually gets into the stomach, and your stomach kind of behaves like a blender where it will keep breaking down the food until it liquefies it. And that liquefied food is called chyme. Chyme. Okay. So at that point, then digestion starts to take place where the food is now broken down on a fancier chemical level and then ready for absorption into the body. Okay. So then it's ready for absorption. And we'll talk about some of that in more detail later. All right. So you need your blood, the blood vessels, and your lymphatic vessels in order to do this. Now, there's other components, but for right now, you need blood vessels and lymphatic vessels to do this. Okay, then food continues through the small intestine as it's being absorbed, and you're getting all the nutrients and stuff that you need. And then eventually it goes into the large intestine. where eventually you will defecate. Okay, so that's kind of a quick snapshot of how food moves through your body. Okay, that's called propulsion, and that is the act of swallowing and the peristaltic wave. So keep in mind your alimentary canal is smooth muscle, okay, which means your autonomic nervous system recognizes the presence of the food and will propel or move the food through peristaltic wave throughout your throughout the canals, throughout the tubes. Okay, going back to assessing people with their health and nutrition and how they eat and what they eat. Some people, because of stress, have a very slow peristaltic wave. So food actually hangs out much longer than it should. Okay, and that actually starts to create problems. If food is not actually moving through your system properly, the hanging out of food, and wait till you see some of this crap, and I mean literally crap, that builds up inside of you when your peristaltic wave is not working right and you have backup and other problems. It's awful. I mean, it can get really, really bad for people. Okay. Um, all right. So some of these, like we've already talked about on that one slide. So if I go through slides quickly, it's because we already talked about it. This is showing you the wave of contraction, how food is moving through the tubes through peristaltic wave. Okay, the oral cavity has a bunch of accessory organs necessary for the breakdown of food. Teeth is one of them. Okay, so as part of my assessment, when I'm working with people, I actually do evaluate their teeth. We talk about teeth. And I'm not a dentist, but the reason why I talk about teeth is because I have found, well, it's not just me. You know, if you practice functional medicine stuff and you help people with nutrition, this is part of the protocol. But I have found that one reason why people may not chew food properly is because they don't have teeth, or they're missing teeth, or their teeth are busted and rotted out and have cavities and holes and they're infected and they hurt. And I'm not kidding. I've caught many, you know, I've been doing this a long time. So many times I've caught this. And you kind of look at them like, whoa, okay. So, you know, you're talking to them and like, well, why do you always chew on the right side of your mouth? Well, because my left side hurts. Well, why does your left side hurt? Well, I don't know. My teeth hurt. Well, let me take a look. So you grab a pen light and you look into their mouth and you're like, okay, what the heck is that? And that, and that, and that, and that, and that. Like, it's crazy what's going on. You know, teeth are chipped, they're cracked, there's holes in them. They have food inside the holes that's fermenting. They, you know, periodontal disease. I mean, all sorts of stuff. And I kind of look at them like, why don't you go get that checked? And here's their answer. Well, because I can still chew on the other side. So I'm fine. It's like, okay, well, you're not fine. And you've got a lot of stuff going on in your teeth. And it looks to me like they're infected, which means you now risk endocarditis. So in other words, your heart can be now infected because of your mouth. You got to get that looked at, buddy. Okay. So I write, you know, if I find that, I write a nice referral order, and with my explanation, and I try to get it across to this patient. I'm like, look, I know you're here because you're trying to do better with nutrition, but part of your problem is you're not eating properly because you have busted teeth. You've got to get that fixed. And then you talking about the risk. If there is an infection, they do risk other infections such as heart infections. Like, that's not good. Okay. So anyway, so teeth are important, and we have, well, we'll get to what we have on the other side, or in a couple of slides. Okay. Okay, the saliva is there to help with, to moisten the food that is in your mouth. Okay, it's very difficult to try to swallow food if the mouth is very dry. So it does create some form of lubrication. We also have some chemicals found in the saliva. Okay, so amylase would be an example, and amylase helps with starch breakdown, which is a type of carb. Okay, so CHO is short for carbohydrate. Okay, starches tend to come from your plant foods. Okay, there are some antibacterial properties found in saliva. And then the presence of the saliva or the liquid also helps with chemical reactions so that your taste receptors, your taste buds, can interpret the taste of food. Okay. Okay, so the saliva glands have two components to them. They have the mucus component, which secretes a type of mucus, and then they have a serous component, which is more of the watery fluid. Okay, that contains ions. So remember, ions are charges, right? So if it's a positive charge, that's a cation ion. If it's a negative charge, that's an anion. So those are your charges. And you have lysosomes, which can break things down, right? They can break down bad guys, so to speak, your lysosomes. And then your amylase, which is a digestive enzyme. Okay, so with our teeth, the parts I would like for you to know is the crown part, the neck part, and the root part. So the crown is pretty much what we see when you look inside of the mouth on your molars. Okay, then you have the neck part and then the root. And so root canals, which is like more of a dental surgical expression, okay, a root canal. Usually what happens is the nerve ends up dying. Okay, there's decay, there's bacteria, and there's just things happening that have now exceeded what your body's immune system can handle. And so now the infection is starting to spread. Okay. And usually starts out with a type of tooth pain, and then jaw pain. It can be utterly merciless and relentless. And if ignored, it can turn into some really serious complications, like bone infection, cellulitis, just really not good stuff. All right. So that's why when I look at some of these people that have these teeth issues, I'm kind of thinking a million steps down the road as to where this is going if they don't get something done soon, right? So you risk just serious infections. And, I don't want a person to have to go through that, because that is a much bigger fire to put out later than just dealing with the small fire that you have now, which, by the way, I still don't fully get that when it comes to, people receiving medical attention. They'll ignore the little things and they'll say, well, it's too expensive. I don't want to spend, $800 to get it fixed. And then it turns into an extremely severe infection, which costs like 60 grand to fix. That's the part I don't get. Like, okay, I understand you may not be able to afford $800, but that's a whole lot cheaper than 60,000 because of the major surgeries and hospitalization stuff you had to go through because of how bad the infection is now. Anyway, just do the best you can to tell them and educate them, and then hope that they, will make a better choice with their own health later. Okay. Okay, don't worry about that page. All right, we do have teeth in youth, right? So your kid's teeth, okay, the child's teeth. And then as you age, you start to lose. In fact, on this one, you can see an adult tooth kind of lying dormant that will eventually rise to the surface and push out your baby teeth, and then your permanent or adult teeth start to come in. Okay, so this one in this child's skull that you're seeing here, you happen to be seeing they removed some of the bone there, so you can see underneath. You can also do this with X-ray. So if you have ever seen an X-ray of a child, which I see, quite a few of them throughout the year, because part of what I deal with is musculoskeletal, right? So it's not unusual for me to look at lots and lots and lots of X-rays. And if I'm looking at a cervical spine, well, sometimes the skull is in there as well, right? So you can see the teeth. And so obviously, because it's a kid, I mean, there they are. The adult teeth are just lying dormant. And as time goes by, they will surface, pushing your baby teeth out. Okay. So the front teeth are the incisors or incisors. And then you have your premolars and then the molars. Okay. Don't worry about teeth counting. I'm not going to get into that with you all. Just we have our incisors, our premolars, and then our molars. Okay, then in the permanent teeth, same thing. Okay, the adult teeth you have, you're supposed to have 32. Okay, once you go through all the teeth maturity stuff and get your adult teeth, 32. In kids, then you have about 20 in number, okay? And you just develop more, especially those molars, as you get older. Okay, so here's an incisor. And then we have a canine, the premolar, and the molar. Now, these are named mostly because the front set of teeth right here are designed to like kind of bite and tear away. Okay, bite and tear away. So that's why they're the incisors and the canines. And then as you work your way back, your premolars and your molars are, they start to flatten out a bit more to turn in more of like a tamp, which will smash food rather than tear it apart. Okay, bigger surface area. So that's one of the reasons for the order and design of the teeth. Okay, the pharynx is the area that's kind of the, you can almost look at it as the throat area, okay, the pharynx. And in this particular spot, well, it does kind of show it. You have the epiglottis that will cover the esophagus. Excuse me, cover the trachea so that food does not go into your windpipe. Okay. So as you're swallowing, the epiglottis will close the trachea to route food into the esophagus. Okay, that happens in the pharynx area. Okay, cranial nerve 10 is responsible for the majority of that work. Okay, cranial nerve 10 is the vagus nerve, and vagus is a derivative of vagabond, and vagabond means wanderer. Okay, so this nerve wanders everywhere. Well, not in that sense, but it wanders a lot of places in your body. Okay, if you look at the anatomy of the vagus nerve, which you would have gotten in A&P1, it branches out and goes to many, many places in the neck area, the throat, in the thorax, right? The heart, the lungs, and so on. So that's where it gets its name, because that nerve wanders everywhere. So the vagus nerve. Okay, we have different specialized like cavity areas inside the body. And one of the reasons for this is you don't want fluid and material and all that stuff in one cavity or one area to be mixed in another's. Like you don't want digestive fluids and digestive things to mix with like your respiratory system. Okay. You really don't want kidney stuff to go into stomach stuff. So your body does break things down. And one of those is the parietal peritoneum. Okay, and then we have the visceral peritoneum that surrounds the basically each individual organ structure. That's why they give it the word visceral. So anytime you have a visceral something, that means it's basically actually touching the organ, like your visceral pleura versus the parietal pleura. Okay, the parietal means more to the outside. It's more superficial, usually not specifically touching an actual organ. Okay, thus the parietal peritoneum. Okay, that parietal peritoneum lines the inside surface of the body wall, and the visceral peritoneum covers the surface of the internal organs. Okay, retroperitoneal tend to sit behind the peritoneum. Okay, so examples of this would be the pancreas, the ascending and descending colon, okay, which is part of the large intestine, and the rectum. Okay, the mesenteries are folds of peritoneum that support and stabilize the GI tract organs. Okay, support and stabilize. Now, if we were, if you ever to look at, wait, let me ask, did you guys with Reeves do you guys dissect cats or any kind of specimen in lab?
I'm not sure what they normally do. We haven't been in class yet. None of us have really been on campus except for skills checkoffs.
Okay. Yeah, we're the COVID crew.
Oh, okay. Yeah. Well, I was just saying, because if you did, even in animals, you can see the mesenteries. Okay, which you're seeing some of that here. All right, yeah, don't worry about this page. Okay, so here's what that greater omentum would look like. Okay, I'm not worried about this stuff because if we were in actual lab and you could physically touch this and dissect it out, then we would get into it. But for right now, here's just a picture of it. Okay, then you have the lesser omentum, and they're named because of the size, the greater and the lesser omentum. Okay, so zooming in a little bit tighter to our GI organs and the GI system, we do have 4 tunics. So tunic is a wall or layer, so 4 different layers or 4 different walls in our system. The inside most is the mucosal layer. Okay, here's another picture of that. So you have basically a tube, right? A canal, the lumen. And this is where you would find the presence of the food stuff. Okay. So that inside most is the mucosal layer. Then as you work your way out, the next layer out is submucosal. And then the muscularis layer. And then the serosa layer. Okay. All right. So blood supply to our digestive system is going to be from the thoracic aorta. Okay, will come down and then eventually turn into the abdominal aorta. And then branches off of that, you'll have the celiac artery or the celiac trunk, which is in the artery family. Okay, the celiac trunk will supply the liver, the spleen, and the stomach. Very important blood vessel. Okay, the liver, the spleen, and the stomach. Okay, the superior mesenteric artery supplies the small intestine and the large intestine, the majority of the large intestine, the proximal 2/3 of it. Okay, the inferior mesenteric artery will supply the distal 1/3 of the large intestine. Okay, so these are the major blood supplies to our digestive system. Okay. I'm a big fan of circulation. You know, one of the things in the whole sports medicine PT world is we do like circulation throughout the body. Okay. In acute situations, we will ice things because that's part of your anti-inflammatory protocol. But once things get into chronic phases, then we want to promote lots of blood supply to the area. The digestive system does require a lot of blood and the presence of a lot of blood to help you break down food. Okay, so that's why if you are in sympathetics, the receptors of the blood vessels in your GI system will vasoconstrict in the presence of epinephrine, norepinephrine. Okay, those are those alpha adrenergic receptors that are located on the blood vessels. The betas allow for vasodilation. The alphas allow for vasoconstriction. Okay. So if you are in sympathetics, your betas are going to be in your lungs, in your skeletal muscle, in your heart, right? So areas that you want vasodilation in sympathetics, but then there's areas that your body does not care about if you're in fight or flight mode. So believe me, if you're in fight or flight mode, your body is not concerned about digesting food right now. Okay. So that's one of the reasons why you get vasoconstriction. So when we're visiting with people that are trying to turn over a new leaf with diet and lifestyle, sometimes some of these people are behind the curve, and we're lucky just to get them to walk for 30 minutes a day. Now, some people are ahead of the curve and they take their exercise very seriously, so I don't have to worry about movement with them. Okay. So if you're already ahead of the curve because exercise is a part of your lifestyle, then obviously we don't really have to go there because you're already doing it. We just encourage you to keep doing it. However, if you're sedentary, that is going to hurt peristalsis, and that's also going to hurt circulation, which will slow down digestive system. Okay, so these are the major blood supplies to your GI, and just as simple as walking after you eat helps tremendously. Okay, and if you guys want to experiment, what most people do after they eat is kind of, let's just say sit on the couch, right? You eat and then you just kind of veg out and you kind of slip into a food coma. All right. Well, after you eat, try going for a walk, especially if you have a dog, take your dog for a walk, even if it's just around the block, see what happens. Okay. Usually digestion improves because you're increasing circulation. All right. So we need these microvilli. Okay, you also might see them as villi. All right, these are important structures to actually help you absorb food. So these are part of the absorptive cells in the body. Okay, we do need our lymphatic system. Keep in mind, your lymphatic system has 3 functions: fat absorption, edema reduction, and defense, right? Your lymphatics are part of your immune system, okay? But with respect to the GI system, it does allow for fat to be absorbed properly, okay? And we're going to draw that out later when we get to some of our longhand notes, okay? Okay, the nervous system, which is part of the autonomic nervous system that helps with digestion, has the celiac plexus, okay, the superior mesenteric plexus, and the inferior mesenteric plexus. Okay, now as far as nerves are concerned, I just happen to be one of those people that believe the brain and your spinal cord and the nerve roots that come out of your spinal cord, right? Like your C3, C4, C5 nerve root, C6, all your thoracics, T1, T2, T3, and so on. And the level of the spinal cord and the nerve roots that come out, for the most part, innervate level appropriate parts. So like your mid thoracics, for example, your upper and mid thoracics will innervate your heart and your lungs. And as you go down, the nerves that come out will operate your gastrointestinal system. Okay. And I also do believe that if you hurt the spinal cord and or the nerve roots, you're going to have decreased function to your gastrointestinal system. So one of the things that we do is we try to improve nervous system function. And because this is non-operative techniques, we do that through exercise, different types of manipulation, the needling, electric stem, traction, all these cool things that are designed to get in there and get the spinal column moving and get pressure off of the nerve roots and stuff like that. Okay, because increasing neurological activity can also help people, in this case, with their digestive system. So the celiac plexus, superior mesenteric, and inferior mesenteric plexus, which ultimately are derivatives of the central nervous system, are important nerves. Okay, don't worry about that. Okay, the esophagus is the food tube. All right, so it does go from the mouth to the stomach. All right, it does have to pierce the diaphragm. So that's the esophageal hiatus. Okay, and you're seeing it right there. The part of the histology that I would like for you to know about the esophagus is the mucosal layer. Okay, the mucosal layer is very, very important to alimentary canal health, gastrointestinal health. Okay, so pretty much all the tubes inside of you have some form of a mucosal layer protective lining. All right. And so another thing to screen people for if you're working with gastrointestinal health are your NSAIDs, non-steroidal anti-inflammatory drugs. Okay, your NSAIDs like ibuprofen, Aleve, Advil, naproxen, stuff like that. Okay. So back to doing a history with someone, we dive into a lot of detail as to what's going on. What kind of medications are you on? Because there are certain side effects of medications that can hurt your digestive system. Okay. How you eat, what you eat, are your teeth even intact? Okay. Are you sedentary? Right. So the history when dealing with someone with gastrointestinal health is quite extensive. Okay, I like doing a very thorough history, and then I like getting the blood chemistry. Okay, once you have all that, now you have everything. And now we have the game plan, because then we can dive in to figure out how to help them. So here's another area you can screen for. Okay, now NSAIDs, such as ibuprofen, I do believe have a time and a place. I do think the medication can help people with pain and inflammation, but I also think that you need to monitor how much NSAIDs a person takes, okay? Because what happens is, as part of the cascade of events, NSAIDs are a COX-2 inhibitor. Okay, so the reason why that's important is that blocks the inflammation pathway. So that's why it's anti-inflammatory. But as a side effect, it also blocks mucus production. Okay, so that's why I'm assuming you all know this, that one of the side effects of NSAIDs is GI ulcers. Okay, gastrointestinal bleeding. Okay, the other side effect of NSAIDs is it can go after the kidneys. Okay, a side effect of acetaminophen, which is Tylenol, goes after the liver, but NSAIDs go after the kidney. Okay, that's one reason why sometimes the recommendation from a primary care or some doc for their patient would be like alternate between Tylenol and NSAIDs. Okay, now they don't say it this way, but what they're saying is beat up the liver a little bit and then give it a break, and then beat up the kidney a little bit and then give it a break. And so you alternate back and forth. All right. People with a history of kidney disease should really never take NSAIDs. Okay, or people with a history of liver disease should not take acetaminophen. All right. Anyway, my overall point here is there is a time and a place for medication, but you also have to be careful on the dose and how much people are taking. So what will happen is, and I, of course, get this quite a bit, I'll have people say, yeah, I'm taking, 3 to 4,000 milligrams per day of ibuprofen. You're like, what? Well, their knee is hurting so bad. Now, keep in mind, they want to continue their run, okay, but their knee hurts. And so what they'll do is they'll take like 1,500 milligrams before they run, and then they go, yeah, then I can get through it. And then later that day, it gets sore again, so I take another 1,500 milligrams of ibuprofen, and then I feel better. Okay, how long have you been doing that for? About 4 months now. You're like, what? Okay, what? All right, so then we start diving into the pharmacokinetics and what's happening and how it can hurt your gut and your kidneys. And so I talk about that with them to try to prevent side effects. Okay, now some people are lucky and they can handle that high of a dose for longer periods of time before their stomach gets hurt. And other people are more sensitive, so it hurts them sooner. So everybody's different on how their body can respond to medication. So that being said, for yourselves, friends and family, and your patients one day, just be careful on how much of these NSAIDs you take, knowing that a side effect is a decrease in the mucosal production. When you take away that protective layer, you now risk gastrointestinal ulcerations. Another way of saying that is gastrointestinal bleeding. All right, and that can get pretty bad. And then you also risk hurting the kidneys. Okay, the esophagus has two sphincters. Okay, you have the upper esophageal sphincter, or the UES, and then you have the lower esophageal sphincter, or the LES, and that one is also known as the cardiac sphincter. Okay, the cardiac sphincter, at least in my world, is what is used more often. So I tend to have a bias toward the cardiac sphincter, even though it's also known as the lower esophageal sphincter. What these do is a sphincter, you can almost look at it okay, you can almost look at it like a valve, where when you touch it, it relaxes and opens up. All right, so the sphincter goes from super tiny, okay, super tiny, and then the presence of food will open it up. Okay, and then when you're done, it closes back down and gets super tiny again. All right, so here's a picture of that. You can see a scope view of the esophagus, that the hole is very small. So really nothing is going to get past it at the moment. But when something touches it, like the presence of food, it causes the sphincter to relax and therefore opens up. Okay, now this one is showing erosions that can happen in the sphincter. And these erosions can come from things like too much acid content, okay, coming up and burning the tissue. And there can be some other things that we'll get into pathophys down the road. Okay, there's that chyme we talked about earlier where once food enters into your mouth and you start to break it down, at that point, it's actually a bolus. Okay, so let's say you took a bite of the hamburger and the incisors and the canines and the molars and all that is breaking down and chomping at the food into smaller and smaller components. Now we're dealing with a bolus because of the presence of the mechanical and chemical breakdown. Okay, once it gets into the stomach and undergoes more of that blender activity, it is now chyme. Okay, so some parts of the stomach I'd like for you to know. All right, so there's the esophagus. Okay, this is where we would find that cardiac sphincter, and that's the cardia of the stomach, and that's the junction of the esophagus and the stomach itself, the cardia. Okay, you're looking at an anterior view here. So you're looking straight onto this person's stomach area. So you're looking right at their abs, for example. So here this is the fundus part of the stomach. This whole thing is the greater curvature. Okay, greater curvature is this. And if you have a greater, you have to have a lesser. So there's the lesser curvature. Okay, another very important sphincter that I do some work on is the pyloric sphincter. So the way this works is you have all this green represents the chyme. Okay. So you have the different muscle layers, the longitudinal layer, the circular layer, and the oblique layer, okay, part of the muscularis or muscle layer of your stomach. And this contracts and churns and all that stuff, part of the mechanical breakdown of the bolus to turn it into chyme. Okay, so the pyloric sphincter, and write this down. It's probably in a future PowerPoint note, but write it down anyway. The pyloric sphincter is the gatekeeper of the chyme. It's the gatekeeper of the chyme. Okay, so what happens is in strategic increments, okay, in strategic timed increments, the pyloric sphincter will relax. Okay, now right now you're looking at the pyloric sphincter basically closed. Okay, so nothing is really going to get by it right now. What happens is in strategic timing, that sphincter will relax. And when it relaxes, it allows chyme to enter into the duodenum, the first part of the small intestine. All right, now that's a very important sphincter function because you don't want the stomach, you don't want the small intestine to be overwhelmed with the presence of a bunch of food at one time. Okay, so that sphincter relaxes, allows a little bit of chyme to enter, Okay, so the work that I do, was mentioning earlier, is when people have an upset stomach, and you can tell through certain tests and certain palpation exams if the smooth muscle if the peristaltic wave in the smooth muscle isn't working right. Okay. It's almost the same feeling as if you go up to and grab someone's trapezius muscle. Okay. So I'm sure all of you have done this. So your upper traps, like close to your neck, right? Sometimes it gets tight. And so you actually touch it and you say, whoa, look at that knot, right? So it's very distinct. Well, it's a similar feeling, but in the smooth muscle. So when you're palpating the stomach and doing certain tests, you can tell if the area is spasmed, okay? So what we do is we do work on it to get it to unspasm, to get the peristalsis back, to get the pyloric sphincter to actually start responding again by unspasming it. It's uncomfortable to go through it. And we talked to them about that, like, this is going to be uncomfortable, but we've got to do it. All right. And so we do the work, and, in most cases, it takes about a minute or a couple minutes. And then all of a sudden, this relief comes in, and it's pretty remarkable. So that's another, sphincter that I like, because it is responsible for the introduction of chyme. And some people, it's not working, so they have stomach problems, and that is a way to help them. Okay, also know that the first part of the small intestine is called the duodenum. Okay, simple columnar epithelium. I, from a histology perspective, love this tissue. And you're like, boy, you are weird. You like histology tissue? Well, the reason why is because of its function. Okay, and when we do our longhand drawings, we'll talk more about why. Okay, but for right now, know that the stomach and your small intestine has simple columnar epithelial tissue. Okay. From a histology perspective, remember, simple means one cell layer thin. Okay, stratified means multiple layers. So that tissue is very thick. Okay, things that are simple, which means one cell layer thick, means that things can diffuse, absorb, and secrete very easily through simple or one cell layer thick. Okay. Diffuse, secrete, absorb. Your stratified stuff, which is very thick, is more abrasion resistant. So it's more for protection. So your gastrointestinal system pretty much does nothing but secrete, diffuse, and absorb, right? You secrete your gastric juices and digestive enzymes and all that cool stuff, and it's going to absorb nutrients. So you want it to be simple. Okay, we do have depressions called gastric pits and gastric glands. Okay, so the GI system is filled with different glands. You need them for mucosal production, you know, digestive enzyme release, and we'll talk about all that later. Okay, but we need these things, the gastric pits and the gastric glands. All right, so there's your one cell layer. Of the simple columnar epithelium. Okay, that would be the gastric pit. And then you have your gastric glands that lie below that. Okay, the surface mucosal cells. Okay, you have the mucosal neck. And then one of my favorites, the parietal cells. Okay, and we'll talk more about that one later too. That secretes intrinsic factor and hydrochloric acid. And that's probably the main cell that I go after in people to get it working again properly with gastrointestinal dysfunction. So we do a lot of specialty things to wake up the dormant parietal cells. Another favorite is the chief cells, which releases pepsinogen. And then the enteroendocrine cells that secretes gastrin into the blood. Okay, we'll be talking more about this one later as we draw things out. But what this slide is trying to tell you is that your body has a reflex. Okay, your body has a reflex to start preparing you for digestion, for eating, for feeding. So the sight and the smell of food, can, you know, if I mean, I'm sure you all have been through this a million times, what I'm about to say. You're hungry and someone's cooking some food, and then you're done with whatever it is you're done with, and then you kind of walk into the kitchen and just the smell and the sight of it, oh, your mouth starts to salivate and your stomach starts to rumble a little bit. Okay, because your body, because of the sight and the smell and the thought of food, is preparing for feeding. Okay, that's a reflex. So your nervous system, your autonomic nervous system, is responsible for that. Then once you actually start eating, the presence of the food, which technically you can kind of look at it like a chemical, okay, your monosaccharides and your polypeptides and the different lipids, you know, the different components that make up your fat, your body does kind of look at that as chemistry. So it starts to break these things down on a chemical level, right? So a different part of your nervous system comes in to start processing all of that, okay? And all of it is autonomic. So we'll get into more of what these things are going to be doing later on. Okay, so once we go from the mouth to the esophagus to the stomach to the pyloric sphincter, now food is going to be introduced into the small intestine. Okay, you have three parts to the small intestine. The first part is the duodenum. The second part is the jejunum. And the third part is the ileum. And that is in order: duodenum, jejunum, and ileum. Okay, the stomach has been removed in this picture. So the stomach would ordinarily be like right here. Okay. So that first part is the duodenum, and then the purple part is the jejunum, and then that kind of pinkish part is the ileum. And the ileum meets the large intestine at the cecum, creates the ileocecal valve. We'll get to that later. Okay, so the absorption part, that is a tremendous function for you, for nutrients and all that, microvilli. Okay, right now I just want you to get a visual. We'll draw out some of these things later when we get to our longhand notes. Okay, one of the reasons for like the up and downs that you see here is it helps increase surface area. Okay, a lot of things can happen in a very small space when you create pits like that. Okay, it increases surface area. Okay, histology of the simple columnar epithelium. By the way, I order a lot of, over the years, I've ordered a lot of biopsies for checking the integrity of the simple columnar epithelium. Because once you do that, they'll look for sprues and infections and, the damaged tissue, that kind of thing. So we'll talk about some of that later, but that's the quick version, is you're just looking for damage. When you take NSAIDs, it actually shrivels the microvilli. Okay. So I go to a lot of functional medicine seminars, and so we get into a lot of histology and we get into a lot of biochemistry, and they start explaining why some of these chemicals and pesticides and all that kind of stuff hurt people on a chemical level. Okay, we get into why artificial foods and artificial flavoring are pro-inflammatory, so it's wonderful work. These researchers do a great job, and they're just presenting to their audience, which are doctors that help people, just this is what's going on. Okay, this is one of the reasons why you're seeing certain ailments in people. So they had histology slides up on the screen, and they showed you this, what healthy microvilli look like. And then they showed a slide of what happens when the presence of the NSAIDs. So if we were to draw this out, these things are nice and long, right? Well, it shortened them. Okay. So it decreased some of the surface area, and it declined some of the protective mucosal lining. Now, once the researchers, had the patient stop the NSAIDs, they gave the body time, and then they went back, they looked at it again, and it does come back. Okay. And everyone was a little bit different how long the microvilli were shortened. But for most people, kind of the average time was like 4 to 6 hours. Okay. So imagine trying to eat food with shortened microvilli during that time. So another reason just to use, try to be really smart about using medication. Okay, the large intestine is kind of your last area to absorb fluids. Okay, so water is continually, it continues to extract fluid from the large intestine. Okay, so that's one reason why, if a person has diarrhea, well, one of the things we know is the stool that is passing through the large intestine is not sitting there long enough to allow the water to fully be reabsorbed into the body. Okay. So then it just passes through as diarrhea. Now there's different reasons for diarrhea, of which we'll talk about that also in pathophys. But as a quick version, it usually has to do with your body trying to purge something. Okay. So if you're dealing with a bacterial infection or just something that your body feels is toxic, you can kind of look at it like throwing up. So, so I think it's okay at first, if your body feels like it needs to throw something up, just let it throw up. Okay. If your body feels like it needs to get rid of this, through diarrhea stuff, fine, get it out of your system. However, it can cross a line and it can become too much. There's too much vomiting, there's too much diarrhea, and now we're worried about dehydration, we're worried about electrolyte imbalances and some other problems. Okay. So, at first it's okay, it's your body's way of protecting itself, but it can certainly cross a line and become a medical issue and needs medical management and or an emergency. Okay, sometimes it can get pretty bad, especially in infants, toddlers, and seniors, right? So the younger you are and the older you are, your body can't quite handle loss of fluids like, let's just say, a young healthy adult can. Okay, I mean, even a young healthy adult is susceptible to injury, but your ped stuff and your geriatrics, they're more sensitive to it. Okay.
So when a patient gets C. diff, what part of the digestive tract is it actually affecting?
Say that again. When a patient gets what?
C. diff.
Oh, C. diff. The intestines. Have you worked with people that have this?
Too often, unfortunately.
Okay. Yeah. What do you see?
I think anyone who's a
Say that again. I missed it.
I think anyone who's been a CNA has,
Oh,
unfortunately.
Oh, I know, right? Gosh, poor CNAs, they kind of get in there, clean all that up. Oh gosh. I heard that CNAs they're not really hiring new ones. Is that true? Or what's the latest on that?
I'm not sure about every hospital, but my hospital that I was at, that I'm not anymore, they've been cutting down big time on staff, so I wouldn't be surprised if they weren't hiring anybody new.
Okay. Yeah, I heard and read a thing on it, that because of the times and, essential versus non-essential and so forth, to cut down on costs, there was kind of a freeze on hiring CNAs. But what's going to happen if that happens is the nurses are then going to have to do the CNA jobs, which is going to piss them off and then create problems. So
yeah, it's kind of been happening even since before COVID. That's kind of what I know from working in the hospital, that they've been cutting down big time on hours and staffing for CNAs. So yeah, I mean, it just takes away from patient care, which in turn is exactly the opposite of what we need to do. But unfortunately, it's all about money. So the
I
patients are
know.
the ones who suffer.
You're absolutely right. Yeah, at the end of the day, it is the patient that suffers, and that's very sad. So
Yet the
hopefully,
only thing they care about.
yeah. Well, hopefully the nurses and everyone will scream loud enough to get the pendulum to swing the other way and get better ratios again, and CNAs and nurses and all that to improve patient care. Okay, bacterial flora. Okay, this is another thing that I find, well, not just me, this is again a functional medicine GI health thing. Okay, balances in gut microflora is very important. Okay, here's kind of the quick version. You do need a healthy balance of good microflora, and it's weird to say, but you do need a balance of kind of the bad microflora. Okay, they kind of feed off of each other. What you don't want is unhealthy ratios. Unfortunately, what's very common is the good bacteria, the good microflora, is declined in people, which creates opportunistic organisms to thrive. Okay. So, one of the things that we do to help with GI is to get the good microflora levels back up. Now, one of the clues that, well, there's a lot of clues, but one of them that a person might have imbalances in microflora, good microflora, is a history of taking antibiotics. Okay. Now, there's a time and a place for antibiotics. It can save your life. It does great work. But sometimes people are just on it for too long and too much. And so now we know that you've also declined in your good microflora. So we do things to build it back up. Okay, one example, and usually where I start people, is saccharomycin. And because that is an antibiotic resistant probiotic. So we'll get started with that one. And then as they get weaned off of the antibiotics, then we go back to like gut rebuilding, microflora rebuilding. Okay. Now that can be a complicated dance because it depends on the infections that they have, the prescribing doc, the medical management. It can be a complicated formula, but there's still a way to rebuild it safely. And simultaneously, what happens as you restore gut microflora, you also boost the immune system. And so then what happens is down the road, they actually become less sick and don't really need the medication stuff anymore because now their body can self-sustain. So we get them off the toxic foods. We switch things over to a cleaner diet, restore gut microflora, improve peristalsis, okay? Have them chew their food completely and, all the other stuff we've talked about. And now you start to see improvement, okay? So earlier when I mentioned all this stuff, on paper, it's easy. Do this, stay away from this. Then you actually start to dive in, and it's actually more difficult than you think to get the GI system healthy again. Okay, it's like telling someone to stop smoking. On paper, it's easy. Just stop smoking. But really, a person really diving in to stop smoking, very difficult. Okay. So you just do the best you can, right? Encourage, and so on. All right. So the bacterial flora can help you synthesize your B vitamins. It's also essential for vitamin K absorption. Vitamin K is a fat-soluble vitamin. In our longhand notes, we'll talk more about how that works. Okay, we'll get into a little bit more detail about that. It does help metabolize some host-derived molecules such as the mucin, the heparin, and hydrochloric acid. Okay, it helps with processing carbohydrates. Okay, and then if you have healthy microflora, it can also help with your acid-base balances in the gut. Okay, now that gets into metabolic syndrome, metabolic alkalosis, metabolic acidosis. Okay, so you're flirting with those problems if you have imbalances in microflora. Okay, the large intestine is this whole thing here. Okay, the different parts to it are the cecum, which is kind of the beginning part of the large intestine. Okay, then you have the appendix, which is this little guy there. All right, there is some evidence that shows that the appendix does behave like a lymphatic organ. Okay, so when the ileum, which is your small intestine, introduces poop into the first part of the cecum there. Now, the reason why I'm saying it that way is because you have to try to keep in mind what people are consuming not only gets into their body, but it does pass through their body. So if they're consuming toxins, okay, your body is trying to purge these toxins. So in some people, a large amount of toxins are actually building up in that cecum area and overwhelming the appendix. So that's one reason why people can get appendicitis. It's just the appendix is overwhelmed, and as a lymphatic tissue, it just can't, the Pac-Mans that are present, it just can't keep up. Okay, so it just gets overwhelmed and swells, and you get appendicitis because of the years and years of toxic material that's being introduced into the cecum. Now, other people get appendicitis because the actual tissue can twist or it's positioned funny. Okay, that's more of a genetic thing. I think that's just how you're built. And unfortunately, if it's malpositioned or twists, then you've cut off circulation and that stuff in there just continues to grow and grow. And then there's that form of appendicitis. Okay. So, and that can be dangerous if the appendix ruptures, all that gangrenous stuff that's in there can seep throughout your body and create a lot of problems. Okay, so usually they have to remove it. So the up part is called the ascending colon. Then you have the hepatic flexure. Okay, it's also known as the right colic flexure. I like the AKA hepatic flexure, because that's where the liver is and that's where it bends or kind of does that 90-degree turn. So that's the hepatic flexure. Okay, then you have the transverse colon because it goes across in the transverse plane. Okay, then you have the splenic flexure, or also known as the left colic flexure. I like splenic flexure. Then you have the descending colon, then the sigmoid colon, and then the anus. So those are the parts of the large intestine. Okay, going back to what I was mentioning to you all earlier about helping people with their peristaltic wave and movement through these tubes. Okay, keep in mind a lot of people with GI issues have poor mobility, meaning the stuff moving through. So this part here has to actually go up against gravity, right? So a lot of things can actually hang out here in the hepatic flexure. So when you palpate, you can actually feel if there's backup in that ascending colon, hepatic flexure, and transverse colon area. And if that's the case, there's some soft tissue, smooth muscle manipulation stuff you can do to help promote movement. Okay. Sometimes parents, if they have a newborn, they're taught this, you know, to kind of do a belly massage on their infant. But you know, you can do the same things to anybody, to adults, and it does help. Now, sometimes the material that's inside of the large intestine is so caked in there that, you know, you're not gonna massage it out, so to speak. Okay. Sometimes even the medication can't get it out, so they'll have to have surgery. And then that's actually called megacolon, where the large intestine starts to enlarge. And oh my gosh, it gets foul. I mean, they'll pull out, and this is no joke, like 25 pounds of crap from the large intestine that's just been hanging out for forever. It can get rough. Okay. Okay, so simple columnar epithelium is what still makes up the large intestine. Okay, we have our goblet cells, which help give rise to mucus. Okay, defecation is the expelling of the fecal matter. All right, let's take a break, and when we come back, we'll dive into some of the accessory digestive organs. So let's take a 15. Okay, liver, gallbladder, pancreas. Okay, the liver, largest internal organ. Okay, it's an anterior view. You can see a little bit of the gallbladder there. And a posterior view, a bigger picture of the gallbladder. Very important vein, the hepatic portal vein, right there. Okay, the liver has 4 lobes, the right and left lobe, and then the caudate and quadrate lobe. Okay, there's the quadrate and the caudate and the left lobe and the right lobe. Okay, so this would be about the person's belly button. All right, so it does favor more of the upper right quadrant area, the liver, that is. Okay, the liver does a lot of things. Okay, it does help synthesize bile. Okay, that comes from your bile salts. It will help store glycogen, so that would be hepatic glycogen. And it does store fat, so a glycogen and lipid reserve. Helps with the maintenance of normal blood glucose levels and to make sure your body has the right amount of amino acids and fatty acids. It can synthesize new things. You know, it can take amino acids and turn them into something if you need it. Okay, so the synthesis and interconversion of nutrients. So transamination. Okay, it does synthesize and release cholesterol. All right, we'll talk about that one later. Your LDLs and HDLs and all that. It will help detoxify you, store iron, and store fat-soluble vitamins. Okay, your plasma proteins come from the liver, such as albumin and globulin. Okay, it helped with the clotting factors. It's part of your RAAS system. Okay, the immune cells inside the liver we call Kupffer cells. So the Pac-Mans in the liver, the phagocytes. Okay, those are Kupffer cells. It is a blood storage site. Does absorb and break down circulating hormones such as insulin and epinephrine. Okay, and it will try to help you process drugs. Okay, so the liver does a lot for you. So liver failure in people creates some significant problems. One of the early signs and symptoms of that, oh, I shouldn't say early, one of the signs and symptoms of that is jaundice, where their body kind of turns a yellow, orangish color. Okay, don't really worry about that slide. Okay, or that one. Okay, the gallbladder, its job is to store bile. Okay, so bile is made from bile salts, which that's a liver function. And then the liver will store the bile into the gallbladder. Okay, the gallbladder is a smooth muscle. So when it squeezes, when it contracts, it will eject the bile, okay, down the cystic duct into the common bile duct and then into the duodenum. Okay, so that first part of the duodenum, let me say that better. The first part of the small intestine, which is the duodenum, is a very important area because it receives a lot of juices from the pancreas, from the gallbladder, and all of those juices are designed to help with continued chemical breakdown of the food. Okay, and we'll talk about some of that in a little bit. Okay, bile. So here's a picture of that where you can see the presence of the duodenum there and these tubes that come from the pancreas and the gallbladder that enter into the duodenum. That's how they get their juices, be it, you know, bile itself or digestive enzymes into the small intestine. So they're released, go down the tubes that we call ducts, and then enter into the small intestine there. Okay,
So what do you have to do if you get your gallbladder removed? Are you then on like?
Okay, so great question. I do work with people that have had their gallbladder removed. That's part of the questionnaire stuff as we're working with GI people, right? So it's a quite extensive history, and that is one of them. Do you still have your gallbladder? Okay, so what happens is, and here's a quick version, because we actually do get into more detailed stuff in pathophys, show you what a diseased gallbladder looks like and all that. If they take out the gallbladder, your liver is still making bile, okay? It just doesn't have any place to store it, so it continues to leak into the small intestine. Okay, now the problem is there's a hormone that's released called cholecystokinin, and that particular hormone is what tells the gallbladder to squeeze. What forces cholecystokinin to be released is the presence of fat. Okay, so if there's a lipid present, and I'm bypassing a lot of chemistry here, okay, just for the sake of time. So a lipid is present. The presence of that lipid releases chemicals, and so the body goes, oh, there's fat, no problem. Cholecystokinin is released. Oh, what does that do? It squeezes the gallbladder. Well, there's bile inside the gallbladder, right? So if you squeeze it, it gets ejected. Well, if they don't have the gallbladder, then their body can't really regulate what's called the emulsification of fats. So that's the function of bile, is it emulsifies, okay? It emulsifies, and what that means is fat and water, okay? So fat and fluid can actually remain together, because normally fat and water want to separate, okay? But in this case, the emulsification process allows these to coexist at the same time so that the body can break it down into further components. And we're going to draw that stuff out later. Okay. So now this person who doesn't have their gallbladder has now eaten a fatty food, which is very common because in the typical American diet, we're eating proteins, carbs, and fats. So let's just say they just had a pizza. Okay, so you're definitely getting all the above: proteins, carbs, and fats. And then they feel like crap after they eat. Like, man, every time I eat pizza, or some people are even intuitive enough where they kind of figure out every time I eat a fatty food, I feel like crap. Okay, so we talk about that. It's like, well, you don't have your gallbladder. And so your body cannot process the emulsification of the fats properly. So now this is passing through your system incompletely digested. And we'll talk about that later. Okay, that gets into the lacteals and the micellization process. Okay, so we'll get into that soon. So you'll see what's going on. All right, so then what we do is we coach them through how to, let's just say, eat smarter, okay? So in other words, they're going to have to not just bombard their body with a huge fatty meal, otherwise they're going to pay the price later. So we control, or they have to control, the amount of fat that they eat per meal, okay? Some of that is trial and error, 10% fat, 20% fat, 30% fat, okay? And then I also combine that with actually giving them digestive enzymes and bile salts to take with their meal. So in other words, once they control the amount of fat they consume, and when they eat, they take the bile salts and the digestive enzymes, it is remarkable improvement for them. Now, it doesn't fix the fact that they have a missing gallbladder, but it does help reduce the amount of irritation they get from meals and certain meals and that kind of thing. Okay. So, and everyone that I've worked with, I usually ask, does anybody talk to you about this? They're like, no. They had their gallbladder removed, and that was kind of it. They just make sure there's no infection and everything's going okay as far as that's concerned, and that's about it. Were you asking, did you have your gallbladder removed?
I did not. I was just curious because I
Okay.
know people get gallbladder surgery.
Yeah. Well, now that you know this, and you work with someone that's had their gallbladder removed, especially if it's been years, yeah, ask them about their diet, about the consumption of fat, and, you know, the condition, or one of the symptoms is called steatorrhea, which is their stool is floating, and it's mostly fat. So it's called steatorrhea. So floating loose stools, mostly fat is found in that stool. And in the long run, that's not good. You do want your body to actually be able to process fats. So culturally speaking, fat does get bad press. Fat is bad, right? Cholesterol is bad. And sugar is bad, right? So we have all these things kind of culturally speaking that just gets bad press. Well, here's what I say about it. I think everything in moderation is okay. I think, if you want to have alcohol, like have a glass or two or whatever, but but don't have 2 liters of vodka a day. Like, a little bit of sugar is fine, especially natural sugar, but excessive amounts all day long obviously isn't good for you. We need healthy fats, right? But too much fat and the wrong forms of fat is not good for you. And on we could go with this. That's just how life is. Too much of anything is not good for you. And then most things in moderation are okay. Okay, once you start with that formula, then you have to get real specific on the person, because everyone's body is a little different. Okay, some people are just more sensitive to things than others, and there's ways to figure that out. But once you have your game plan, yeah, everything in moderation is okay. Oh, and then the cholesterol, and we'll talk about that later too. We actually do need cholesterol to function. Cholesterol does make your bile salts. It makes your androgen hormones, which is testosterone, estrogen, and progesterone. It's part of the integrity of your cell membranes. So it gives it some of the integrity and strength in the phospholipid bilayers. So cholesterol, even though given bad press, is not in and of itself bad for you. We actually need it. It's once it starts to get outside of normal ranges and there's other things that start to spin cholesterol out of control where it can hurt us. Okay, just like sugar. We actually need sugar, but too much is not good. If you have alcohol, a little bit's fine, but too much is not good, and so on. Okay, so there's your yellow-green alkaline solution, the bile salts that's derived from cholesterol that emulsifies your fats. Okay, this is one reason why a person can turn jaundice, is because the liver is not able to process and keep this yellow-greenish material contained within itself, so it leaks out into the system and ends up getting into the skin. Okay, bilirubin is a pigment that comes from heme. Okay, so heme is the blood components, so like hemoglobin, right? So the bacteria break down the intestine to sterocobalamin, is what gives the brown color, what gives feces the brown color. Okay, the pancreas does release its own pancreatic juices. Okay, that enters into that duodenum. All right, we do have the tail of the pancreas, the body, and the head. Okay, and you all by this point should know the main pancreatic cells. Okay, the alpha cells release glucagon, the beta cells release insulin, and the acinar cells release your bicarbonates. HCO3. Okay. Alpha cells, glucagon. Beta cells, insulin. Acinar cells, bicarbonates, HCO3. Okay, we'll talk about this stuff later. Okay, we'll get into that later. Okay, absorption is the body's ability to take the food and actually get it into your system. Okay, most of this is done by active transport, which eventually gets into the blood. Okay, in the small intestine, and we'll talk about this as we draw some stuff out as well with the fat-soluble vitamins A, D, E, and K. In order for this to be adequately utilized, you do need to go through a micellization process. Okay, and I'll get into the B12 and we'll get into all this as we draw stuff out. Okay, electrolytes. Which are not iron, ions, right? So positive, your cations are absorbed in the duodenum area, okay? Calcium, for example, about 80% of calcium is absorbed in the upper part, the early parts of the small intestine. Okay, so sometimes I work with people who have osteopenia, osteoporosis, and they were told, well, just take calcium. And then I get them and I'm like, the calcium is not even getting into your system because you've got so much gut inflammation. The absorption is just not happening. Okay. And so we focus on reducing gut inflammation so that that intestine can start to absorb in this case, the calcium that it's supposed to. Okay, so that first part of the duodenum or the small intestine is very important for absorption, including your electrolytes. Okay, another thing is iron. A knee-jerk reaction is if a person is iron deficient, is just to give them iron, which makes sense, right? Oh, you're low in iron. Well, just take iron. Well, you have to be careful with that. Their iron actually may be fine. It's the transportation of the iron and the stored iron within the ferritin may not be working right. Okay, so when you do an iron lab, you're going to look for, you order the ferritin, you order the transferrin, you order total iron binding capacity, the TIBC, and then iron itself. Okay, so before you take iron as an actual supplement, these labs are important to have first. And depending on the values, now you may or may not actually give iron. Okay, so in other words, sometimes the ferritin is not releasing the iron like it's supposed to. Sometimes the transferrin, which is transporting the iron, isn't working right. Okay, so that's why we look at the different labs to get, if those aren't working, we get those working, which gets their iron stores back up without even giving them iron. So that's why you got to be careful just taking an iron supplement. Okay, calcium and vitamin D. So a lot of people are deficient in vitamin D. Very common, very, very common. Another thing we test for. So when you look at what vitamin D does for your body, I mean, it's like a textbook an inch thick. There's so many things that vitamin D and the form cholecalciferol does for us, okay, which is actually D3. And one of them is helps with the absorption of calcium. So if a person has a calcium problem, chances are they have a vitamin D problem and vice versa. So this is another reason why I like doing labs on people, is your body tells us exactly what's going on, and then we can go from there. Fix deficiencies, fix inflammation, and so on. Okay. A lot of water is absorbed from the small intestine. About 95% is absorbed from the small intestine. And then around 7% or so or more is absorbed from the large intestine. All right. Any questions on any of that stuff? Okay. On this next one, go ahead and grab a sheet of paper. And I'm going to do a screen share with you to going to draw some stuff out here. Okay, so in the mouth, right, you have those different glands, the parotid, sublingual, and submandibular. Okay, and they release amylase, which is a carbohydrate starch breakdown into sugar. All right, so you will almost, I guess, sarcastically hear me reference carbs as a sugar. Okay, so sometimes I just use those synonymously with each other, because at the end of the day, your body does break this down ultimately into a sugar form. Okay, so if you hear me say sugar and carbs, oftentimes I'm doing that synonymously with each other. Okay, the stomach. Okay, here's the esophagus and yeah, not bad. Okay, there's the stomach. Okay, so cheap cells release pepsin, which helps you digest proteins. Okay. The parietal cells release hydrochloric acid and intrinsic factor. Okay, hydrochloric acid has a lot of functions, Okay, one of them is going to be to kill bacteria. Okay, so that's one of the reasons why if you have this condition called hypochlorhydria, which by the way is very common, what it means is you have a decline in hydrochloric acid release from your body. So the parietal cells are not working properly. Okay, the usual suspects for hypochlorhydria would be proton pump inhibitors. So people taking PPIs, or in lay terms, acid reducing medications. Diet, lifestyle, right? Stuff we've mentioned before, like stress. I mean, are you eating stressed? The quality of food. Another word, is this creating inflammation, gastrointestinal inflammation? Okay, another thing that hypochlorhydria will cause is a decrease in protein breakdown. Okay, and if you're like, well, what does that mean? Well, here's what it means. When you eat a protein, it's kind of like one big convoluted ball. Okay, if you can look at this like a ball of yarn. Okay, we're going to take that ball of yarn and unravel it into a long polypeptide chain. Okay, now what is found on that polypeptide chain are individual amino acids. So in other words, a bunch of amino acids lined up together create a polypeptide chain, and all of that in a big wad ball of yarn, that's your protein. So hydrochloric acid plus pepsin equals unraveling. Well, let me say that better. Unraveling is fine, but the breakdown of protein into its individual amino acids. So that polypeptide chain is supposed to be eventually broken apart and the individual amino acids taken in a good way so that your body can use them later for protein synthesis stuff, which is done in the rough endoplasmic reticulum of your cells. Okay, so I don't want to get into too much pathophys stuff. We'll save that for pathophys. But for right now, as an easy, quick version, just recognize that the chief cells do release pepsin. Parietal cells do release hydrochloric acid. Hydrochloric acid has a lot of wonderful functions. Kills bacteria, helps unravel proteins. Intrinsic factor's job is to bind to B12. Okay, to bind to vitamin B12. And this is what helps you absorb the B12. So if people are taking those proton pump inhibitors, they risk having B12 deficiencies. Now, in pathophys, we'll talk about what happens when intrinsic factor isn't working right and hydrochloric acid, all this stuff isn't working right. We'll get into more detail with that later. Okay. So as far as normal function, you want the chief cells to release the pepsin, you want the parietal cells to release hydrochloric acid and intrinsic factor. Also, on a quick clinical note, if the protein is not being acted upon properly by your different gastric juices, you're going to get incomplete raveling of the polypeptide chain, which means when the protein goes to pass into the small intestine there, it's too big of a particle. And guess what is activated? In the inflammatory process. And then you get a lot of these guys that come into the site to start to do their job. Okay. And oh my goodness, that creates a whole nother slew of problems. All right. The liver, well, the gallbladder, let's do gallbladder. Okay, let's see. So the liver kind of looks like this. Okay, and then that gallbladder hangs out about there. Okay, so there's the gallbladder, liver. Okay, so the liver takes bile salts, makes bile, stores that in the gallbladder. Okay, its function is lipid digestion. Okay, and it also helps to facilitate the formation of missiles, not spelled like ballistic missiles. Okay. The missilization process helps you so it helps you process dietary fats and the absorption of your fat soluble vitamins, vitamin A, D, E, and K. Okay. Also, the bile allows for fat and water to be together. Okay, which that's an emulsification process. All right. Pancreas. Let's see. Looks something like this. Okay, your tail, body, and head. Okay, and I'm putting these cells in really no particular order here, but we have cells that release trypsin. Chymotrypsin. Okay, these help break down proteins. Okay, that's the pancreas's version of helping you break down protein. Okay. The pancreas has its amylase, which helps you break down starches. Okay. Lipase. So pancreatic lipase breaks down fats. And then what we mentioned earlier with the alpha cells, the beta cells, and the acinar. Okay. Glucagon, which is responsible for gluconeogenesis. Beta cells, insulin, which helps you get sugar into glucose into the cell. And acinar cells, your bicarbonates. Okay, and that helps neutralize the acids. Okay, bicarbonates also help ionize bile salts. And this ionization process helps emulsify better. Okay. All right, small intestine. So let's do our stomach. Okay, there's that stomach. And then let's call that the small intestine. Okay, so this is the duodenum part that eventually turns into the jejunum and so on. Okay, so small intestine. All right, we have these special cells inside called brush border of intestinal epithelium. Okay, so those brush borders they're delicate and they function a lot of digestive breakdown and help with some absorption process. Okay, so like for example, lactase. Whoops, I misspelled that. Okay, lactase breaks down milk sugars, okay, which is a disaccharide, which is lactose. Okay, and some people just simply lack lactase, so they can't break down the lactose, which is a sugar, a type of disaccharide sugar, or your milk sugar, and so they're going to have problems. Okay, sucrase. All right, which breaks down sucrose and fructose. Okay, so sucrose is your table sugar, and fructose is fruit sugar. All right. Maltase. Breaks down maltose, which is found in plants. Okay, and it converts that or breaks it down into glucose. Okay. This is where we start to get into celiac disease. Okay, I'm going to save a lot of that for pathophys, but the quick version of celiac disease is the person has an adverse reaction to proteins. Okay, there are different proteins inside of the gluten family. Now, we don't really have a lot of time to get into that. It's a very long discussion, but here's the quick version. There's a bunch of different type of proteins found in the gluten family. Okay, so the big ones are the gliadins and the prolamines. Okay, sorry, the glutelins and the prolamines. Okay, you don't have to write this down, but the prolamines, they're found in wheat, barley, rye, corn, oats. Okay, the glutelins have different subcomponents of them. Okay, they are similar to the prolamines in their protein content, and they're also found in wheat, barley, and rye. Also found in the endosperm of rice. Okay, and we can keep going. There's kind of a pecking order to this. So there's this protein, and then there's another one and another subprotein, and it keeps going down the list, found in different foods, right? So found in your wheat, found in your barley, found in rye, found in rice, found in oats. Okay, so what ends up happening, and I'm about to bypass about 30 hours worth of data here. Once a person consumes this, you create inflammation because their body now looks at these proteins as a bad guy, so an antigen, which activates the immune response. So when that happens, you're going to bring in like 1 million different Pac-Mans. Okay, I don't know the exact number. I kind of made that up, but a lot. You're going to bring in a lot of various form of Pac-Mans, and they're going to start to do their job. So all of that is part of the inflammation cascade of events. Now, earlier I told you we do tests, okay? So one of the panels you can do is a celiac test. Which encompasses a bunch of different immunoglobulins, okay? And those are different antigen antibody markers. Another one that I do, and I do these simultaneously. I do not want one without the other, and that is genetic testing. Okay, the HLA DQ8 class 2 antigen receptor gene. Okay, so that is a genetic test, the HLA, human leukocyte antigen, DQ8 class 2 gene. So I want the immunoglobulin celiac panel, but I also want the genetic marker. So let's say, for the sake of argument, they both come back positive. Well, back to our, is this a fad? Is this just a thing? Are restaurants just trying to make money and stand out from other restaurants? Well, maybe. But if this is true for this person, yes, they are going to have to go gluten-free. And yes, it would be nice for that particular population to still be able to go out and enjoy the evening. You know, I think that's great, right? To be able to go out for your friend, with your friends, you know, family, a date, whatever. Enjoy a football game at a bar. Now, for other people, all of this is fine. And so if that's the case, then you would have to be careful of the type of gluten that you eat, okay? And what I mean by that is, does it have all those pesticides in it? Is it genetically modified? And so on, okay? So we'll actually talk more about that when we come back from break, okay? And then also when we come back, I still want to cover some liver stuff, some triglycerides, okay, and a few other things. All right, any questions before we break for lunch? Okay. Liver. All right, earlier we mentioned a bunch of functions of liver, like stores of glycogen, and it synthesizes your lipoproteins. Okay, so the The lipoproteins are your VLDLs.
Supposed to be seeing something. I don't see anything.
Oh, okay. Okay, how
There
about,
we go.
all right,
Yep.
thank you. So I just wrote down liver and then lipoproteins. And we're gonna list a few of those lipoproteins. And VLDLs is one of them. Okay, very low density lipoprotein. Okay, then you have low density lipoproteins or LDLs, and then high density lipoproteins or HDLs. Okay. Let's see. So the liver, I'm just gonna kind of draw a very simple animation of what's going on with these lipoproteins. All right. So VLDLs are made in the liver, and when they get released, they get converted and released as LDLs. Okay. And you can look at an LDL as a carrier protein, and inside of it, you have a bunch of cholesterol. Okay. And this is circulated throughout the body. And the cholesterol is deposited to tissue wherever cholesterol is needed. Okay, so one of the jobs of the low density lipoprotein carrier protein is to transport cholesterol so that it can get to different tissue in our body. Okay, so on one hand, this is a good thing. We'll get into the problem in a little bit. All right, then we have the HDL. And right now we'll look at it kind of like a deflated balloon. Okay. So a deflated balloon, if you put enough air or something into the balloon, it will go from deflated to inflated, right? So what happens is all this extra cholesterol that's floating around in your system, the HDL goes and picks it up. And so the more things that you put into the deflated balloon, or in this case, the HDL, it will enlarge. So it goes from this small HDL, high density lipoprotein component, to larger, because inside it just picked up a bunch of the extra cholesterol. And then eventually it gets back to the liver, where it releases the cholesterol, and the liver will remanufacture it and basically start over with the VLDLs released as the LDLs, floats around in your system. The HDL picks it up, sends it back, and things are basically recycled. Okay. So that's why the LDL is known as the quote and unquote bad cholesterol. Okay. Now, I don't personally agree with that statement. I understand why they say it, which I'll show you in a little bit. But the body is just doing its function. So to me, LDLs aren't necessarily bad guys because it's part of how we utilize our cholesterol. Okay. And then the HDLs are known as the good cholesterol because it is what takes up the excess, or the excess amounts of cholesterol, and brings it back to the liver. Okay. And the way that we increase HDL levels, the best way actually is exercise. Okay, lots of studies on that to show increasing HDL is through exercise. So with your cholesterol scores, the higher the HDL number, the better. The lower the LDL number, the better. Okay. The higher the HDL, the better. The lower the LDL, the better. In general, that's kind of your rule. Okay. All right. Okay. Triglycerides. So TG for short, that is triglycerides. Okay, tri is 3. Okay, when we eat, keep in mind we're assuming this is the typical diet: carbohydrates, fats, and proteins. Okay, especially the carb part. So when we eat, CHO or carbohydrate, all right, you activate insulin, and insulin, the presence of insulin activates the synthesis of lipoprotein lipase. Okay. Lipoprotein lipase breaks down your triglycerides into their fatty acids and sugar. Okay. The fatty acids are eventually stored in adipose tissue. Okay. Sugar is now present in the body. And in healthy people, some of that sugar is utilized as energy. Because insulin was activated, Okay. Um, okay, because insulin was activated because you just ate a carb, it's going to take glucose and transport it into the cells. All right. In diabetics, excuse me, in diabetics, especially type 1, they do not have insulin. Okay. So remember, insulin activates lipoprotein lipase, which breaks down your triglycerides. So if a diabetic is not releasing insulin, especially if they're not managing their diabetes through insulin shots, which is actually common and eventually common amongst diabetics. And I think a lot of it is because they're over it, right? I mean, if you've had this your whole life, you're tired of pricking your finger and testing yourself and giving yourself shots and that kind of thing. But either way, at some point, it seems like diabetics just things spin out of control. Okay, so insulin activates lipoprotein lipase. And so diabetics have a decreased ability to break down the triglycerides. All right, and this will lead to increased blood levels of triglycerides, which increases fatty acids, like free-floating fatty acids, which go to the liver, and now you are at risk for fatty liver. Okay. All right, now triglycerides, when everything is functioning just fine, okay, this is a good thing to have, just like cholesterol. If things are within normal limits and doing what they're supposed to do, they're fine, right? Triglycerides are a major source of energy. They're transported. Now, I did skip some biochemistry here, but triglycerides are transported in the blood as a lipoprotein. Okay, and your lipoproteins are your chylomicrons, VLDLs, LDLs, HDLs. Okay. right, so let's bring in gallbladder and pancreas. Okay, and your duodenum. Okay, the duodenum. All right. Okay, now triglycerides will eventually get into the digestive system. In the presence of bile salts, okay, and then lipase from the pancreas. All right, so we now have bile salts and lipase. Plus the triglycerides. Okay, so now they're behaving together with the triglycerides. Plus the micelles. Okay, the micellization process is going to act upon the triglycerides, and a micelle is a tiny lipid droplet, okay, that was emulsified by the bile salts. Okay, so you want the micellization process to take place. Okay, now the micellization and the triglycerides and all that travel to the microvilli. Okay, and back when we were looking at that, those are the finger-like projections in the small intestine, the absorption site. Okay, so here, the microvilli aids in absorption of your fatty acids. Okay, now by this time, it's a fatty acid plus triglyceride plus an apoprotein plus phospholipids. Okay, now all of these enter the bloodstream. Through the lymph. Okay, so your lymphatic system is part of fat absorption. Okay, it helps with just how we process fats. Now, some people, this isn't working, so they bypass the microvilli, they bypass the lymphatic, and unfortunately, it will enter into the bloodstream not completely broken down, so they have large particles of fat floating around their system. And we can measure that, right? So we can get your triglyceride levels. And if you have high triglyceride levels, typically the knee-jerk reaction is to put them on a statin drug, whereas in functional medicine, we try to get all this stuff, the microvilli, the lymphatics, the micellization, the bile salts, okay, the digestive enzymes of what they eat and how they eat, and I'm working my way backwards. meaning, you know, you get into the gut and all the chemistry in the gut. Well, where did all this come from to begin with? Well, it's what you ate and how you ate, what you're actually putting in your mouth, right? Incomplete chewing of food, quality of food gets into the stomach, the hydrochloric acid and all those juices are not really breaking things down. It passes into the large intestine, it passes into the small intestine, incompletely broken down. There's inflammation there, right? Because they're likely sensitive or allergic to the food. On top of it's, if it's artificial foods and that kind of thing. Plus, they're likely eating stressed out anyway. Okay. They likely have crenation of the microvilli, decreased mucosal lining because of stress, side effects of medication. So now you can see why on a biochemical level, things aren't working quite right. So it bypasses the way it's supposed to get into your system and just gets into your system incompletely broken down in too large of particles, which will eventually cause problems. Okay. So yes, as a bias of mine, I do think it is better to get them to get their gut healthier and change diet rather than just rely on statin drugs. Because what will happen is if you put someone on statin drugs and you don't change what they're eating and how they're eating, you kind of don't really make the problem go away. Okay. So some people, we have to do both. Like things are so bad, they have to be on the meds, but we're also doing some dietary changes and some other really cool things to get gut function back. And if we see them kind of doing a good U-turn, a turn for the better, and you're monitoring through labs over time, you can start to wean them off the meds. Now, sometimes people cross the line of no return and, you know, they have to rely on certain medications and stuff, which I understand that. But even if they cross the line of no return, you can always do an anti-inflammatory diet, increase their exercise, and try to get them to eat clean. Always. That never hurts anybody. Okay. It just gets a little bit more complicated if you can or cannot wean them off of meds. That's a more complicated dance, but you can always improve best you can, you know, people's quality of life by incorporating healthy things with diet and lifestyle. Okay. So the chylomicrons, which is a type of transport protein, okay, allow fat and cholesterol to be transported in a fluid environment. Okay. So by this phase, that's when it enters lymph and then blood, the bloodstream. Okay. Now, I said it earlier, fat is not necessarily bad for you. We need fat, we need proteins, we need carbs. Okay, we need our macro and micronutrients. But we also need to try to consume foods that, in simple terms, are clean, a clean diet. So, you know, best you can, fresh fruits and vegetables, lean meats, and stay away from pro-inflammatory foods and artificial foods and things that have known toxins in them, pesticides and that kind of thing. Okay, now going to the PowerPoints I emailed. I want to do the one that's titled cholesterol. So let me share that with you. Okay. So cholesterol is an important dietary lipid. It makes bile salts, steroid hormones, which is your estrogen, progesterone, testosterone. Helps with vitamin D production and is a major component of the cell membrane. So about 15% of cholesterol comes from diet. About 80% of cholesterol is made in the liver. Okay, because cholesterol and triglycerides are insoluble in water, they do not circulate very well in the bloodstream. So that's why they are transported in those lipoproteins. Which are your HDL, LDLs, and VLDLs. Okay. We already talked about that stuff. We kind of drew it out. All right. As far as a score, okay, there's different authors that say different things about cholesterol. But one, you can look at LDLs as under 200 milligrams. Some will say, 160 or less. I've even seen some as strict as 130 or less. Okay, and you'll see in a little bit what's actually going on here and why this score to some degree actually doesn't really matter. I mean, it matters at some point, but to split hairs between 130 and 160, 180, you'll see why in a minute, why it almost doesn't matter, okay? One of the ideas is if you have high cholesterol, you're at risk for atherosclerosis. And this is what can clog arteries and cause strokes and heart attacks. The HDL is considered the good cholesterol. And this one, the higher the score, the better. So 60 plus is really good. 35 is even though normal ranges are 35 to 60. The higher the better for HDLs. Now, inflammation is really to blame for blood vessel issues. Okay. So with chronic inflammation, which actually this would be 14 days or longer. Okay. So chronic inflammation, microorganisms that produce toxins that can stimulate tissue damaging reactions. Okay, so this is what you should be concerned about, not necessarily, a score of 190 of LDLs, but tissue damaging reactions from microorganisms. In other words, inflammation, prolonged irritation of chemicals, irritants, and other mechanical abnormalities. Okay, other things like tuberculosis, silicosis, rheumatoid arthritis, polymyositis, toxoplasmosis, which can lead to an enlarged liver and spleen, so hepatosplenomegaly, swollen lymph nodes, calcium infiltration, so calcium is being deposited, hyalinization, which is like a type of scar tissue, and other abnormal tissue repair. These are the things that you need to be worried about. And people have these, right? And, I was trying to say that earlier with, the toxins in the system. And then some of these are, can be environmental, like you happen to be working in a factory and you're breathing in all of these chemical and physical irritants like dust, sand, like coal miners, that kind of thing. Also, you'd have to understand the difference between repair and resolution to understand how the body heals. So we get an injury, and then what happens? Well, the body does try to heal. Well, if the body can resolve itself or resolution through the mitotic proliferation, the structure goes back to its original form. So basically, you go back to 100% with resolution. Some tissue can do that, and some people can do that, besides Wolverine. Repair, now this is where most of us are at. Okay, so in other words, repair, when you get hurt, okay, your body heals, but not to 100%. Okay, so it depends on the severity of the injury, the person themselves. Are they an elderly person? Are they young? Genetic stuff. There's a lot of things to factor in. But when you get hurt, it heals, but it doesn't go back to 100%. Maybe it went back to only 90% function. Maybe it went back to only 50% function or whatever. So the replacement of destroyed tissue has scarring. The body tries to restore its tensile strength, tries to get the healthy tissue back, but it has limitations, so it just can't. So now you take these things and you look at a blood vessel and you realize that we have the tunica intima, right, the insidemost layer, and there's a little crack, okay, enlarged here. You can see the little crack in the tunica intima. So hypertension, smoking, hyperlipidemia, so too much fat stuff floating around in your body, hyperhomocysteinemia, so the inability to process proteins properly and you get some abnormal byproducts of protein metabolism, hemodynamic factors such as constantly being in turbulent flow. You want to be in laminar flow, but turbulent flow is present. Toxins, viruses, other immune reactions, and so on. Okay, bottom line, inflammation starts to hurt the tissue. So the tunica intima is damaged. And the body goes, oh, no problem. I can fix that. I have cholesterol. I will bring in the LDLs, even if I only had 1 milligram of cholesterol versus, 160. I'll find the injured spot and I will work on fixing it. So what happens is the provocative thing, so the inflammation, all this stuff, and you can add to the list as much as you want, has not been removed. So the body continues to create cracks and tears and fissures. So the body continues to repair it. All the while you're narrowing the lumen, and eventually you're going to get a heart attack. Now I like this one because it shows you a little bit better of what's going on more of a chemical level. So there's your LDL, the so-called bad cholesterol. Okay. So they get activated, they get recruited. So the LDLs enter the intima through the endothelium. They get oxidized because of, or get turned into these pro-inflammatory lipids. which causes adhesions and recruits monocytes and T lymphocytes. So the monocytes come in. Then the monocytes turn into macrophages. Okay, the macrophages start to consume all of those LDLs. Okay, so now you're seeing the oxidized LDLs right here. So those yellow balls with the little black spikes on them is letting you know that's oxidized LDLs. And they turn them into foam cells. Okay, so you're seeing the foam cells now being released. When they're released, the foam cells release these growth factors, so these cytokines that encourage atherosclerosis. And all the while, you're continuing to form that so-called plaque or lipid pool, because this is your body's way of repairing. That's why earlier I was saying LDL is not necessarily the bad guy, even though we call it the bad cholesterol. What the bad guy is the inflammation and the injury. And so then your body comes in and does its repair mechanism by constantly oxidizing the LDLs, turning them into foam cells, then releasing them, and eventually that's turned into your lipid pool, taking your otherwise healthy lumen, okay, your otherwise healthy, nice open tube, and slowly closing and narrowing the tube. And then at some point, you're going to get, 98% blockage, 100% blockage, and that's going to not be good. Okay. So what I'm a bigger fan of is trying to get people to reduce the amount of inflammation in their body and to improve the integrity of the tunica intima in the blood vessel. All right. Also, there's this thing called the VAP test. Okay. The VAP test is a much better test than just your cholesterol panel or your lipid panel. Because the VAP test looks at 5 different subparticles of cholesterol. And if you really want to see your risk factor for developing atherosclerosis and artery disease, do the VAP test. It's also called the LPP test. It has 2 names, the VAP test or the LPP test, the lipid particle profile test. It is a phenomenal test, top end, state of the art, best of the best. It looks for the 5 different subcategories of cholesterol, and it will give you your risk, the percent chance of atherogenesis, right? So in other words, are you at no risk or are you at extremely high risk, depending on the subparticles on the VAP test or the LPP test that shows up. Now, I order labs for people, and yes, we do get your basic lipid panel, which tests for LDLs, HDLs, triglycerides. That's fine. But what's better is to see what the subparticles are of the cholesterol that are the ones that actually do the damage. And some people it's really high, some people it's in the middle, and some people it's very low. And then once you know, then you can go down a much more accurate game plan to age into healthy blood vessels. Okay. Now, I've been doing this a long time, and this is very rarely ordered by the medical professionals, and I don't really understand why. They just typically do the lipid panel, and then if it comes back high, then they look at, then they just put them on statin drugs. And then eventually, some point down the road, I get the same patient, and so we do a little bit different route through diet and lifestyle changes, and then I order the LPP test, and then that gives me a better idea of how serious this problem is or isn't. and then based on their results, we go down that route of trying to protect their blood vessels, the tunica intima, and that kind of thing down the road. Okay, the next one is the nutrition basics. Okay. So in general, people eat carbohydrates, proteins, and fats. So fats are broken into your fatty acids and your sugar, proteins into their individual amino acids, and carbohydrates into their monosaccharides. Okay, a lot of this we've talked about already. Oh, what the heck? That was supposed to get into, well, we'll just write it out. There's another thing I want you to know. Here, let me go back. Hold on. Okay, so here's what I also want you to know. That a carb is, in 1 gram, you get 4 calories. A protein, in 1 gram, you also get 4 calories. And in fat, in 1 gram, you get 9 calories per gram. Okay, so this is your so-called counting calories. Okay. So if you just ate something and let's say it had 30 grams of carbs and 30 grams of protein and let's say 50 grams of fat, well, you just do 30 times 4, 30 times 4, and 50 times 9, and you will get your total calories. Okay, so that's the part. I thought it was on the PowerPoint stuff, but we'll just write it out. Okay, so that person just consumed 690 calories in that meal. Okay. And then with water, okay, you want to try to consume about 64 ounces per day. Okay, for an adult. All right, so about 64 ounces. Especially in this area, since we live in a dry environment and we're at altitude, we can lose water to the environment very quickly. So it's important to stay hydrated. Now I have a 32 ounce, stainless steel Nalgene bottle type thing. So I try to consume at least two of these a day. Okay, 2 of these 32 ounce Nalgene bottle type things. But you can also count into that 64 ounces any juices that you drink, such as orange juice, apple juice. Okay, that does qualify to some degree. Coconut water, electrolyte drinks. I do a more natural version of electrolyte drinks. So in other words, Gatorade has too much sugar, too much salt. It's got food coloring in it. It's got too much junk in it. But there are some natural electrolyte supplement type powders you can get. You just add it to your water, and you're getting a little bit of calories, a little bit of healthy forms of sugar and your electrolytes, and sometimes they add multivitamins like B vitamins and stuff like that. Okay, so I do enjoy that because it makes the water less boring. Okay, you can also get it from fruits and vegetables. So most fruits and vegetables are saturated with water, so that does count to some degree. So it doesn't necessarily have to be 64 ounces of actual water every day, but it's 64 ounces of good fluids, the majority of that being water. Okay, and that can be divided up with your juices, your actual water, fruits and vegetables, and electrolyte drinks. Okay, any questions or anything over this or today's material? All right. I have